Assalamualaikum doctors, welcome to our 22nd session of report-based discussions. So today we are going to cover these 7 topics. We have a list here. So let's start from the first one. So first one is perianal abscess, and perianal abscess is not there in MTB, so I should take you to AMBOS. So here we have this one, perianal abscess, and unfortunately it's not there in very much detail in AMBOS as well. So only 2 lines are there for perianal abscess. We know very well what do we mean by abscess. Whenever there is a pus collection there because of the infectious agents, that is called abscess. So maybe it can be a cyst first, and then later on cyst can be infected and can become an abscess, or maybe directly an abscess formation can be there where you can find a cavity who is filled with pus. So as the name indicates here, it's a perianal. So it should be surrounding the anal area. So that is called perianal abscess. So what you're going to see exactly the appearance of this abscess, we find this erythematous. It must be a red fluctuant subcutaneous mass near the anus found by manual inspection. So once you do the manual examination, you just place your hand, and what you will observe and what you will feel that there is a subcutaneous mass which is just around anywhere area around the anal area, anal opening. That is called perianal abscess. And if I can show you here in the diagram as well, if you can appreciate this diagram, this is the rectum, this is the anal canal. So see, this area is considered to be the perianal area because this area is just surrounding the anal area, and here you will find this abscess. So it may be here, it may be on other side, but it should be surrounding the anal canal. So that is called perianal abscess. Similarly, you can find this is ischiorectal fossa. There is an abscess here called ischiorectal abscess. You can find in between external and anal sphincter there is an abscess called intersphincteric abscess. So these are all the anatomical landmark based abscesses, where on the basis of the position you will just name them. And similarly, this is levator ani muscle, and if any abscess is just above this levator ani muscle, you can call this as a supraelevator abscess. There's one more point extra here in this abscess medicine. Here you can see, especially again the clinical findings of this perianal abscess, there must be a throbbing pain. The patient must be having pain because it's infectious. The cavity is filled with pus, so the patient must be having pain. Continuous perianal pain. There may be erythema, fluctuant, swelling. There may be swelling in the ischiorectal fossa as well. On digital rectal examination, you can appreciate on digital rectal examination. You can appreciate on manual examination this perianal abscess. So for the treatment part, only 1 line is there. Of course, whenever there is an abscess, you always have to go for incision and drainage. So you will go for surgical incision under local anesthesia. You will do the local anesthesia, will provide locally. You will just anesthetize that area and you will cut that abscess and drain the fluid. Or maybe you can give antibiotic cover later on if it's too much infected. Let's have a look at the question here. Here the question says, a 40-year-old diabetic patient complains of a painful perianal swelling. So here they have clearly mentioned that this 40 years old, he is a diabetic person and he is having this perianal swelling with fever for the last 3 days. So those who are presenting with swelling and those who are having fever should always come in your mind that it must be a perianal abscess. The blood pressure is okay, heart rate is a little bit on higher side, temperature is, of course, he's having fever, 38 degrees. When you check the results, hemoglobin is okay, ranges are there for you. Of course, the fever is there. It means that there is some infection going on in the body. So the patient WBC must be raised. And if on examination you find the neutrophils count are increased, always consider about bacterial infection. Whenever you will find lymphocytosis, you will always consider any viral infection. That is a basic clue. On the basis of CBC report, you can have an idea whether it's a bacterial infection. If you find neutrophils count more than the normal, of course, if it's normal is 60% up to, and here you will find 80%, it means that it is more than normal and this infection must be a bacterial infection. But if you find lymphocytosis, like lymphocyte count is increased, that must be a viral infection. Of course, he is a diabetic patient, so glucose level must be high, or if he is on insulin and on diet control or on strict control of metabolism and glucose metabolism, then you may find normal level of glucose. It is in common observation that diabetic patients usually have infection, and if they have high level of glucose levels, the infection usually heal. Infection usually takes some time to heal. That is the common observation in case of diabetic patient. Wound healing is always delayed in diabetic patient. So which of the following is the most likely diagnosis? Of course, based on the area, that is a perianal swelling, and he is having fever. So this is a clear-cut case of perianal abscess, because based on the position and based on the finding that this patient is having fever, this patient is having perianal pain, when you do the examination, you will appreciate this subcutaneous mass just beneath the skin around the perianal area. That is a perianal abscess. Okay, for the next one, we have to go for the theory first. Next, we have this tension pneumothorax. So whenever we say about tension or whenever we say pneumothorax, we always consider this thoracic trauma. So we have different kinds of thoracic trauma. The main heading is actually the thoracic trauma. So always remember, whenever there is some injury to the chest, maybe because of the road traffic accident, maybe because of motor vehicle accident or any traumatic history, that can lead to thoracic abnormalities. And here we are considering tension pneumothorax. So pneumothorax usually mean that when air occupies the pleural spaces, when in the lungs, all over in the pleural spaces, if there is accumulation of air, we can always say it's a pneumothorax. And of course, tension pneumothorax always build when there is a trauma history. So air in the pleural space through a one-way leak. So air comes and trapped there, and there is no passage from where the air can go away. So of course, there is only one passage. The air can only come and trap, and it won't be able to release from that area. Then you can say it's a tension pneumothorax. And what is the presentation, how your patient is going to present? The patient must be having this chest pain. Of course, that must be a first physical finding. You're going to see first physical symptom the patient is going to express. There must be hyperresonance. When you do the percussion, because there is underlying too much air accumulation, you will find hyperresonating percussion and decreased breath sounds. So of course, because of the accumulation of the air in the pleural spaces, you cannot easily hear the normal breath sounds. So these are the typical findings, and one finding on the basis of which you will say it is actually a tension pneumothorax, that is the tracheal deviation. Very, very important point, because once the tracheal deviation word is there, you can easily make a diagnosis of tension pneumothorax. So tracheal deviation is always away from the involved lung. I will just show you in the X-ray. You can appreciate that wherever the tension pneumothorax is there, trachea must be away from that side. Say for example, left lung is having tension pneumothorax, trachea you can appreciate on the right side. If right lung is having pneumothorax, tension pneumothorax, you can see trachea on the left side. So of course, you can easily diagnose on the basis of chest X-ray. And what you will do, your main goal is to decompress the area. Your main goal is to release that air. So you will, of course, you can introduce the suction tube in order to just decompress that area. So tension pneumothorax pushes the trachea away from the involved lungs, and if there's a case of atelectasis, that always pulls towards the involved lungs. So that is just a discrimination point. But for our tension pneumothorax, please remember that you will always find trachea on the opposite side. So let me show you this diagram. See, this is the tension pneumothorax. If you can just appreciate, if on the X-ray you will find too much blackish area, it means that too much air is occupied here in the pleural spaces, and this is a clear case of tension pneumothorax. So if this is the right side, if this is the right side and this is the left side, so can you appreciate this trachea? This trachea is little bit deviated here. So there is a tracheal deviation you can appreciate on this side. So the tension pneumothorax is on the right side, but tracheal deviation is on the left side. So trachea deviates towards the left. So it's a clear case of tension pneumothorax. So if we go back to the question and see here, a young man was brought to the emergency department after he was hit in the chest while playing football. Now you have a traumatic history because he is having this football who actually hit the chest wall. On examination, he was dyspneic. Dyspneic means he is having chest pain and drowsy with GCS 11/15. So his Glasgow Common Scale, who's showing he's oriented with time, place, and person, is also decreased. Of course, it's not very much decreased. If it's in between 7 to 8, we have to intubate the patient, but it's not like that. Still, he's drowsy, and 11/15 is the score. Tracheal shifting to the left and raised JVP were noted. He has barely audible breath sounds on the right side. So of course, there will be accumulation of air on the right side. Because of that, you see the patient is having decreased breath sounds. So if the tension pneumothorax on the right side, so it's true written here that tracheal shifting to the left. So once the breath sounds on the right side is decreased and trachea is on the left side, tracheal shifting on the left side, and he is having a clear traumatic history, it means that this is a clear case of tension pneumothorax. So when you do the examination, blood pressure is low, heart rate is high, respiratory rate is 32 per minute is high, but breath sounds is not audible or decreased breath sounds. Temperature is okay, oxygen saturation is okay. So based on the traumatic history, based on the tracheal deviation on the opposite side, based on the decreased breath sounds, we can say this is a case of tension pneumothorax. This is quite clear case. For the next one, we have to go for the here also we can solve this question. A 33-year-old man was brought to the emergency department after a high velocity trauma. Again, there's a traumatic history. He had distended neck veins and markedly decreased breath sounds on the right side. So it's clearly mentioned that this patient was having a history of trauma, and now he's having this decreased breath sounds. Of course, heart rate is high, blood pressure is low, oxygen saturation is low, again 85%. Which of the following is the most likely cause? Now you have seen here that the breath sound is on the right side. So what do you think? It is a right tension pneumothorax or it is a left tension pneumothorax? Of course, if the breath sound is decreased on the right side, then it must be a right pneumothorax. Only the tracheal deviation will be on the left. But if it's mentioned here left side, then we will say it's a left side pneumothorax or a left side pneumothorax, but must be tracheal deviation on the right side. So trachea will move on the opposite side, but whoever the side of the lung is having decreased breath sound, you will say the same tension pneumothorax. So this patient is having decreased breath sound on the right side, so he must be having this right tension pneumothorax. Okay, for the next one, we have to go for the theory first. Now we have this breast cancer screening. Screening questions are very important, especially two screening. One is colon cancer, one is breast cancer screening, and especially also when we are doing pap smear, what are the typical ages of doing the pap smear? So these are the three things you always find we call based on these one. So please, these are very important topics. Go for them. So here we are covering this breast cancer screening. I'll take you to here 1979. Okay, so for breast cancer screening, always consider that what is the typical age where we can start this breast cancer screening, because this cancer has a very good prognosis if we can diagnose this in early stages of life. So say for example, here they are saying this United States Preventive Services Task Force, they are saying that we have to conduct this cancer screening should be conducted every 2 years in the general population, starting at age 50 and ending at age 74. So if a woman is having a normal family history, there is no family history of breast cancer in her family, and absolutely the family is free of any kind of cancer, and now she's presenting to you, then you can counsel her that at the age of 50 years you should start for breast screening, and you should undergo this mammogram that is considered to be the best screening tool for breast cancer. But say for example, if the patient is having a family history of breast cancer, say for example her mother was having the breast cancer at the late ages, or maybe her sister is having this breast cancer, or maybe her aunt was having breast cancer. So if you find any kind of family history, any kind of breast cancer in her family, maybe first degree relative, maybe second degree relative, then you should counsel your patient that you should start screening earlier, a bit earlier as compared to the normal one. So that in that case, you will start screening at 40 years. So that's why your good history taking is very important here, that we will always inquire about the mother, especially the sister, especially the aunt. So first degree, second degree should be evaluated. And then if there is no family history of breast cancer, you can counsel your patient at the age of 50 years, you should start screening, and then every 2 years. So if, for example, her age is 50 years right now, you will ask them to again go for the mammogram on 52 years of age, and then 54, and then 56. So every after 2 years, you will ask her to come and go and check her this breast cancer screening through mammography. But if there is any history, you will ask to come early, like 40 years of age. So that must be the protocol for this breast cancer screening. So now let's look at the question here. A 35-year-old woman is considered about Concerned about her mother, history of invasive breast cancer. Now her mother was having a history of invasive breast cancer. She is 35 years old and sister with ovarian cancer. It means that there's a cancer history in her family. Sister was having ovarian cancer, mother was having invasive breast cancer. Her clinical examination was unremarkable, no doubt. She is absolutely at this time like 35 years of age. But which of the following is the most appropriate best breast cancer screening? So what you will advise? You will advise her that based on the history of invasive breast cancer in your mother, you should start screening your breast, especially through mammography at the age of 40 years. So you will advise her to come after 5 years for the breast cancer screening through mammography, and then every 2 years. That should be the protocol for her because she's having the invasive breast cancer history in her family. So we will not go for the ultrasound. Ultrasound is not going to be considered to be as a breast screening tool. BRCA gene testing again will not consider for this one. For especially for the breast cancer, we are not bothered about BRCA one. Breast self-examination, that has to do every month after menses. So that is a normal thing that the patient can do. It has nothing to do with the screening part. So screening, we will always go for mammogram. So you will counsel this patient that at the age of 40 years, you should undergo this mammography every after 2 years. Why? Because you have a strong family history of breast cancer because your mother was having invasive breast cancer.
Excuse me, Dr. Hira, Assalamu alaikum.
Walaikum assalam. Ji, Dr. Tan.
I didn't know the class was at 10 a.m. I thought it was at evening. I just checked my mobile and you have invited for the class.
Yesterday I told you just after the session.
I don't know. I heard it.
Maybe. Because of Saturday, no? Because of Saturday.
My laptop was in a charge and took a lot of time in joining in.
It's okay, no problem. We did 2 topics. Just go through the recording and let me know if you want to ask anything.
And why not BRCA gene? BRCA gene is also for breast detection.
Yeah, BRCA gene is there, but we usually do this BRCA gene testing when you found anything on mammography. So that is the secondary test. And especially for the ovarian cancers, we usually perform this BRCA, not only for the breast cancer. But if someone is asking exclusively or isolatedly for the breast cancer, then only the mammography is the best screening tool. This is one of a kind of a confirmatory test because there you will find exactly the gene who is mutated one and responsible for cancer.
Okay.
That is the secondary test.
It is advanced.
Now, advanced kind of, yes. Okay. The next one, we have to go for the theory. Next, we have this Wilson's disease. So we can cover it from MTV. Okay, so Wilson disease, this is a disorder of abnormally decreased copper excretion. So normally there is a phenomena of every metal, whatever the metals we have in our body, they usually excreted with the help of carrier proteins. So we do have carrier protein for copper in our body that is called ceruloplasmin. So ceruloplasmin is one of the carrier protein who will take the copper, free ion copper, plus 2 charged ions are there on the copper. So they will just take this copper ion and it will conjugate with this ceruloplasmin and then it can easily excrete it into the urine. So that is the normal mechanism of copper excretion. But what happens if there is because of any reason, and this ceruloplasmin is usually formed in the liver because it's a carrier protein and most of the carrier proteins formation occurring in liver. Now what happened in this Wilson disease, if there is low ceruloplasmin, if we see there is low ceruloplasmin or if we see this plasma protein is low because liver is not forming enough amount of ceruloplasmin, then we can think copper is not excreted and it builds up in the body, in the blood, maybe in the body, in the liver. So it's going to start accumulating. So the whole point is this, that when you find the ceruloplasmin level, you will find it low levels. Now, maybe it's going to accumulate in the liver, it's going to accumulate in the kidneys, in the red blood cells, and the nervous system. So you may find this copper accumulation anywhere. And one of the very, very important findings which you've seen in your patients who are presenting with Wilson's disease, you can easily relate this Kayser flessuring on her eyes. So just on outside the corneal layer, if you can find brownish deposition. Let me show you the picture. This one. That's just in the Descemet membrane outside the corneal lining. If you can find this copper deposits here in the form of this brownish deposition, you can say it's a typical presentation of this Kayser flessuring. It's a typical presentation in those patients who are having copper accumulation. And why this copper is there? Normally copper should be excreted out, but there must be some metabolic error where the liver is not actually forming the ceruloplasmin. So when you check the ceruloplasmin level, you will find low ceruloplasmin level. It means that that's a copper deposition. So how your patient is going to present who is having this one? So only acute, okay, this one is nothing to relate with this one. What is the most likely diagnosis? So in addition to all previously described features of cirrhosis, here we will see the features, some neurological manifestations. So if copper is accumulated in the body, what it can do? If it's going to accumulate or deposit in the body, it can cause some neurological symptoms. Say for example, the patient may present with psychosis, may present with tremor, dysarthria, ataxia, and seizures. But most of the time, those who are having Wilson disease, we usually find tremors in these bodies, or we usually find dysmetria. Like you will find movements, some disorganized movements. And why these disorganized movements are accumulating? Because of the copper deposition. Copper is going to interfere with their normal metabolic activity, especially the carrier protein, because carrier protein is not there. So it's not going to excrete it out, and this copper can easily form salt and can easily mimic as, inhibitory. Sometimes it mimics as inhibitory neurotransmitter, and it can cause these type of neurological symptoms. Similarly, we may find some hemolytic anemia. If it's going to accumulate it in the blood, you can see what will happen here. It can cause hemolytic anemia. The blood vessel is going to be lyse because of the deposition of the copper, because that's not a normal thing in the blood vessel. And usually spleen is very sensitive about catching all these things which are very abnormal in the blood. Or we may find renal tubular acidosis or nephrolithiasis. If this copper is going to be accumulated in the liver, it can cause the nephrolithiasis. It can cause or it can form the renal stones. We may find renal stones because copper can form easily a salt, and that salt can be deposited and can be accumulated in the renal system and can cause nephrolithiasis. So you may find different presentation, and most of the time you will not find every all these symptoms. Sometimes the patient usually presented with this neurological symptoms. Sometimes they may present with hemolytic symptoms. Sometimes they present with renal system. So you have to particularly evaluate all these symptoms and just make a diagnosis. But this Kaiser ring, is very much obvious. Whoever is having this copper metabolism, copper deposition. So that is a very clear-cut clue for us. We can, of course, relate with the symptoms, but if on eye examination, if you find this brownish deposition just around the cornea into the descending membrane, you will say it's a clear case of Wilson disease. So for the diagnostic test, we'll always go for slit lamp examination, and there we'll find this Kaiser ring, a brownish ring around the eye from copper deposition, and of course ceruloplasmin. We know very well the pathophysiology is ceruloplasmin, that once it's low and it's not forming from the liver, it can cause this one. So what you will do, you will check the liver we can go for the liver biopsy, but of course that is considered to be the most accurate test, sensitive and specific, and will detect abnormally increased hepatic copper. So if on biopsy we will find increased hepatic copper, of course that is going to confirm the diagnosis. But through slit lamp examination, your best initial test, you should have an idea, okay, this is copper deposition. So the most accurate diagnostic test is looking at abnormally increased amount of copper excretion to the urine after giving penicillamine. Now, what is happening here for the treatment part as well? We have to use, because whenever the ions are accumulating in the body, we always have to give some compounds called chelators, and these compounds are the one who is going to take this metal ions and help in the process of elimination. So we can say the elimination of these ions can be happening with the help of this chelating agents. And what is the chelating agent here which we are using for the copper? That is the penicillamine. So penicillamine is the one, although we are using it as a treatment part, but you will clearly see by giving the penicillamine if copper excretion is increased in the urine. So that will also give you a clue, okay, that was a copper. So this penicillamine is actually going to do what? It's one of a chelating agent. It's going to bind with the free copper and it's going to excrete that copper through urine. So this is also one of the best part of your treatment. So the decreased ceruloplasmin level is not the most accurate test. Of course, you have to go and check for the ceruloplasmin level, but that is not considered to be the most accurate test. When we say most accurate test, that can only be the biopsy, where we can easily visualize, okay, hepatic copper is too much here. It means that the copper is accumulated here and the copper is not excreted out. So treatment, we will use this chelating agents, copper, that is penicillamine, and remove it from the body. Additional therapies, you can also use zinc. Zinc is going to interfere with intestinal copper absorption. So this is, this is one of a kind of counter transport. When zinc is going to attach and it's going to release copper, that is called counter transport. Or maybe we can use this tryntine, that is an alternate copper chelating agent. But for your exam point of view, you should remember penicillamine, because penicillamine is the one who is a chelating agent who is going to take copper and excrete it into the urine. It's one of a kind of diagnostic purposes as well and treatment purposes as well, because it's one of a chelating agent. So if we just have a look at the question here. Here the question says, a 23-year-old man comes to the physician because of a tremor in his right hand. So tremor, 23 years old, one of a kind of neurological symptom. For the past 3 months with history of excessive drooling at night, again one of the neurological symptoms. He has had several falls over the past month. His vital signs are within normal limit. He has a history of this fall history as well. We don't know why it's the reason why he's having too much, why he's so much prone towards fall. Maybe the gait problem, maybe the posture problem, maybe the musculoskeletal problem. His vital signs are within normal limits. Examination shows a broad base gait with +4 deep tendon reflexes. Hyperreflexia is again one of the neurological symptoms. There is a low frequency tremor that affects the patient's right hand to greater extent than his left. So one side is having more tremor activity as compared to the next. Again, tremor. Tremor again means neurological manifestation. Now, dysmetria is present, again, neurological manifestation. Patient's eye on examination showed Kayser flessuring. Now you have a clear-cut clue that why he was having so much neurological manifestation, so much neurological presentation, because he was having this copper deposition and that was purely affecting the brain. That's why he's having this one. So Kayser is there. So clear-cut diagnosis must be in your mind that this is Wilson's disease. Now what they're asking, which of the following is the most appropriate pharmacotherapy? What you are going to do? So if Kayser is there, so for the diagnostic point of view as well, you will give penicillamine to this patient and you will check whether the copper excretion is increased or not. So if copper excretion is increased, it means that this is a positive, this is truly a Wilson's disease. So penicillamine is not just going to go and act as a treatment part, but also it will help you in the diagnosis of Wilson's disease as well. So here we will go for penicillamine because it's one of the chelating agent. Or say for example, if penicillamine is there and they're asking you what can be the next one, then you can think about zinc. And what can be the next one? You can think about tryntine. So there are 3 things actually we are using, but always the first one is penicillamine. Now, for the next one, we have to go for the theory. We have this ape hand. Ape hand we will cover from Ambers because it's not there in MTB.
But Dr. Hira,
yes, dear.
How we will think about copper and this?
Because in this question, Kayser ring is there now. On examination, slit lamp examination.
Ring will not come in our mind. When there are neurological symptoms, there are a lot of neurological problems.
Yes, of course. If Kayser ring is not mentioned, you can never think about Wilson. No. You cannot think about Wilson without Kayser. Never ever. Because the young boy who's having too much tremor activity, that can any be of neurological problem. You cannot, you cannot comment on that. Only we comment because we have this Kayser ring. If Kayser ring is not there, you can just put in your provisional diagnosis that maybe I should go and check the slit examination and check the eyes. Maybe I can find something there. So that is only in your provisional diagnosis. But if Kayser is there, then no point. You should always think about this one. So that's why we have to do the complete clinical examination. Yeah.
My question is even how we can think about Kayser ring. There are a lot of neurological problems, neurological deficit.
No, but see, if you have a clear Kayser ring, then you should always first think about this one. If you give penicillamine and there is no copper excretion, then maybe you can think about other neurological problems. But the first thing should hit in your mind, that must be a Wilson disease, because Wilson is always, mostly 99% cases must be presenting with neurological symptoms. Sometimes blood symptoms, you can also find anemias as well sometimes. So there is always a correlation. So that's why you're not saying it's a definitive diagnosis. Definitive diagnosis you will always made on the basis of most accurate. Once you are done with the
I'm
most
asking
accurate
how we will think about copper and about Wilson's. There are a lot of neurological.
Based on Kesering. If Kesering is there, you have to think about that one.
So we have to examine we have to examine his eyes.
Yes, and even not only on the slit lamp examination, sometimes you can evenly, through your naked eye examination, you can appreciate this brownish discoloration in the eye. And once you do the slit lamp examination, you will find little this brownish depositions around the cornea. So that will, make you a clear diagnosis. Yeah, true. Yeah, these eyes you can easily distinguish. These are brown eyes, typical brown eyes. The one who is having brown cornea, that is something different. But if you can see the brownish line,
I understand that point.
Yeah.
My question is, even how we can think about Wilson's and cases with lot of have neurological problems.
First you have to think about this one, and then you can rule out the other neurological problems. If you find a clear cause, then there is no ambiguity. Okay, if you cannot find, let's say for example, after giving penicillamine is not only the treatment part, it's the diagnostic purpose as well. Give penicillamine and check for 1-2 days check the urine levels for copper. If copper is high, then of course it's a clear diagnosis. Then if you find after giving penicillamine there is no copper change, you cannot find copper in the urine, then of course you have to think about the other thing. So you must ask patient to undergo for several testing in order to make a definitive diagnosis. Just on one day presentation in OPD, you cannot make a diagnosis of Wilson's disease, of course. It will take some time. Okay. So now let's come to this one, ape hand. So ape hand is not very much in detail, but just here we have this, especially the disease condition where we think about which nerve is going to decompress here and which nerve is going to damage here in this condition that can cause ape hand. So we have this median nerve. Let me show you where exactly this one. So ape hand is what? It's just looking like the hand of ape, the pathology. If you can just appreciate that monkey is one of our primates, just belong to the human species as well. So if you can just appreciate, this is ape hand and this is a human hand. So if human hand is just going to represent like this ape one, and why is that so? Because of the damage to median nerve. And what kind is here? Inability to oppose and abduct the thumb, because median nerve is the nerve which is actually going to supply 3.5 fingers, lateral 3.5 fingers of our hand, the motor distribution. So if there is inability to oppose and abduct the thumb, if the patient's thumb is not abducted means away from the midline, and abducted means towards the midline. And opposition means that like the way we are counting, we just put this thumb with the little finger, that is called opposition. So this phenomenon is going to lost here due to injury to the proximal or distal median nerve. So there may be any reason. There can be any reason where we can see the median nerve is going to get damaged, and because of the damage, maybe trauma, maybe some motor vehicle accident, maybe some incidental trauma, anything can happen. Maybe there is only just the compression of the nerve. So owing because of any reason, if this distal median nerve is going to damage or decrease supply, then what it can do, it can impair the thenar muscles function. Thenar means thumb muscles and hypothenar means little finger muscles. So then what you will see this presentation, especially here, this prominence at the base of the thumb. So here you will find these muscles, the nerve is not going to activate all the lumbricals, all the hand muscles, and that's why there will be no abduction of this finger. It cannot oppose this one, and the hand will be straight like this one. This is called ape hand. So just think about that median nerve is going to damage, and because of the median nerve damage, we will not find any motor activity on the hand, especially the lateral 3.5 fingers, and especially the motor activity is damaged. The thenar muscles are especially damaged, and the presentation of hand is like an ape. You can say it's an ape hand deformity. So let's have a look at the questions here. Okay, the question says a 26-year-old man is brought to the emergency room after sustaining a bullet injury to his arm. So there was a bullet injury, especially occupying this arm area. Examination shows his median nerve was damaged. So if median nerve was damaged, which of the following is the most likely clinical finding? So what do you think? Do you think it's a claw hand? This claw hand is the damage to the ulnar nerve. So ulnar nerve is damaged, then it can produce this claw hand or a ulnar hand. So of course, this is not the right answer. Wrist drop usually occur when there is a damage to radial nerve. So of course, again, this is not the correct answer. Waiter's stiff hand, we have already covered this one. Waiter's stiff hand is injury to the brachial plexus, C5 and C6. So of course, this is not the answer. So once it said median nerve, you will always think about ape hand because that is the peculiar presentation of median nerve injury. These questions are easy to see and easy to solve. Now we have the next one. Next, we have polycystic kidney disease. So polycystic kidney disease is there in MTB, but very short para. So I think it's better to go with AMBOSS. So as the word indicate polycystic kidney disease, so you can think about there must be too many cysts inside the kidney that can lead to polycystic kidney disease. And if we can just have a summary, look at a summary of this one. So this polykidney disease is an inherited disorder characterized by the development of multiple cysts. So it can be an autosomal dominant disorder, it can be an autosomal recessive disorder. So depending upon the gene presentation, we will see it is classified into two. Some may present with autosomal recessive thing, like if only one gene is involved and one is normal, this is not going to be a dominant in a patient. That's called autosomal recessive. And if one gene is involved and the patient is going to show the symptoms, it means that is autosomal dominant. So this one manifests, if we are considering autosomal recessive one, they are saying manifests with severe pulmonary insufficiency and progressive renal failure. So those who have this autosomal recessive disease, they even show the symptoms, they even show this progressive renal failure with onset during infancy or early childhood. So of course, it's a hereditary disease. It must be started from the beginning. So in the early childhood, in the infancy, you can start appreciate this one. If left untreated, this autosomal recessive is typically lethal before adolescence. So if it's a recessive disease, you will always think about the manifestation must be starting from very beginning. Like in early childhood or in early infancy, you can see the patient is having problems. But in case of autosomal dominant one manifests with flank pain. So if the patient is having this polycystic kidney disease who is having on autosomal dominant gene, then we will see the patient may present with flank pain. Of course, that's the presentation, arterial hypertension because of these cystic presentation in the kidneys, and progressive kidney disease with onset in adulthood. So what you can do, what you can memorize here for your exam point of view, if the child is presenting to you with the features of renal failure, you should always have a DD in your mind that this child can have this autosomal recessive polykidney disease. And once you evaluate, once you do the diagnostic testing, you can confirm that thing. But if the adult patient is going to come with you with the renal problems, then again you can think about polycystic kidney disease, but that should be autosomal dominant polycystic kidney disease. So for the sake of memorization, we can think in this way: autosomal recessive can present in early childhood and infancy, and if the presentation is in the later age of life, we can think about autosomal dominant one. So early diagnosis and treatment may prevent, of course, end-stage renal disease. You can prevent your patient by going into this end-stage renal disease, but kidney transplantation is the only curative treatment. So of course, here we have too many cysts in the kidney. The normal functioning of the kidney is compromised heavily. So what we can only go for kidney transplantation. Now, you can see the incidence is quite high in autosomal dominant one, 1:1,000. The most common inherited cause of chronic kidney disease. So the one who is having CKD, you should always have this in your mind that the patient may have this polycystic kidney disease. Now, responsible for 5 to 10% of end-stage renal disease. So those patients who are presenting with ESRD, that is end-stage renal disease, once you sort out the etiology, you will always find, and you will always come to know that this patient was actually having polycystic kidney disease. That's why they are now ending up into end-stage renal disease. Okay, so what is the clinical presentation if the patient is having this autosomal dominant? This one symptom usually occur after 30 years of age, but the disease may also manifest during childhood. Of course, it's not hard and fast, but usually we will see the presentation is quite common in adult patients who are having this autosomal dominant thing. Symptoms are less severe and tend to manifest later in individual with this mutation compared to the one who are having PKD1, those who are having recessive. So as compared to the recessive one, this dominant symptoms are less severe. So symptoms are less severe, but the end result is
why is there a different representation of autosomal dominant recessive disease?
Yeah, sorry, you're asking about the symptoms or you're asking about the etiology?
I'm asking about why is there difference? It's dominant and recessive. What is the difference? Why representation?
Yeah, see, these polycystic kidney genes, we have actually two genes. One is called D2 and one is called D1. PKD1 or PKD2. So those who are having deletion of this gene PKD2, they usually present with autosomal dominant one. And those who have deletion of this PKD1, they are presenting with the recessive phenomena. So that is just a genetic phenomena, you can say. Like two genes are there who are responsible for creating this cystic kidneys. One is called D1, one is called D2. So if D1 is deficient, we say it's a recessive one. And if D2 is deficient, we say it's a dominant one. Like
yeah,
it's going to
present, okay, I know, it's understand. But why is it there's a difference in their manifestation in early life and adulthood?
It depends, like what this gene is going to actually do. What are the functions of that gene? So say for example, if D1 is okay, we are considering that this is a recessive gene and it's going to create multiple cysts in the body, but the presentation is very early and it's very drastic in the childhood. So it's all about its presentation.
Excuse me, recessive is here carried on X or Y?
X, of course. Y never carries this. And Y never carries these things. Only X.
And dominant carried on?
Dominant means if only one X is involved, the other X, even if normal, then we can say the others. We have two types of chromosomes, sex chromosome and the other chromosome.
So they will be carried on X or Y?
X, of course, X. Y never carries anything. Yeah.
Y never carries any genes?
But that is about sex chromosome. We are here asking about the normal autosomal chromosomes. So if we are, because it's not a sex related disease. So we are not bothering about XY and XX. We are only bothered about XX only. Because in males also there are 22 XX and only one XY. In females, all 23 are XX. Are you getting my point?
Yeah. Yes.
Yeah. So don't confuse with XY and XX because we are not talking about sex-linked inheritance. This is not a sex-linked disease. It's an autosomal disease. We have two types of chromosomes: autosomes and the sex chromosomes. Sex chromosome, which are making which are differentiating with the male and female. So it's not a sex-linked disease. We are only considered about the 22 pairs of XX chromosome of male and 22 pairs of XX.
There are a lot of diseases which are carried X. The X-linked, the X-linked, dominant X-linked.
So when we say X-linked, it means that we are considering about the sex X character. That is a sex-linked, always sex-linked.
You see hemophilia and this.
Yeah, that is a sex-linked disease. Means you can also find on that chromosome which is actually maintaining the sex of the patient, like XY or XX. So if on that condition also only male X is going to carry, Y will never carry this one.
Okay. So
this one, for this one autosomal, we are considering only the autosomes, the 22 pair of male and 22 pair of female. In that, if you see only one X is having this gene deletion and it's showing the dominancy of this disease, that is a dominant one. If that gene is having this one, the chromosome is actually showing the deletion of D1, but the patient is not having symptoms at all, we can say it's a recessive disease.
Okay.
So now the presentation is very important, which we are going to memorize here. For exam point of view,
but recessive is presenting earlier in the life.
Earlier in life. That's why we are saying it's autosomal recessive. Mostly we will see in early and dominant later in life. But again, they have mentioned that it's not in hard and fast. You may find early childhood result, but mostly presentation is in adult life. Yes. Now, yeah. So coming back to the point here, this autosomal dependent, this one, not dominant, this one, the renal manifestation, you should know that they may present with gross hematuria. Of course, whenever there is a blood in urine, we will always think about some renal compromise. Flank abdominal pain must be there, recurrent UTI. So think about kidney and think about the kidney symptoms and kidney presentation. So they can all be there. In fact, nephrolithiasis can be there, stones in the kidney might be palpable in large and abdominal examination, and signs of CKD are very important. What are the signs of CKD? If the patient is presenting with hypertension, blood pressure, if the patient is having too much fluid retention inside the body, and if the patient is high level of uric acid and high level of blood urea nitrogen, that is called uremia. So if the patient is having all these symptoms, we can say these are the symptoms of CKD, chronic kidney disease. So the one who is having all the symptoms of CKD, we have to evaluate. We should know the cause. Maybe it can be a polycystic kidney disease. So that's a genetic factor. We can easily convey and counsel the patient that it's just a genetic reason. We cannot do anything with this one. It's not an acquired one. It's not an infection or something. It's actually your genes who are responsible for ending up in this CKD problem. Now, for extrarenal manifestations, so not only the kidneys are going to be involved, but maybe sometimes you will see some extrarenal manifestation in these patients. Say, for example, these patients can also have some, in combination with the renal cyst, these patients can have hepatic cyst as well. Or the presentation may be that there are cysts in the pancreas, spleen, ovary, and testes as well. So if you will find there's a kind of syndromic activity. Not only in the kidneys we will find cysts, but sometimes it's not always polycystic kidney disease present with all the cysts in every other areas. It's not like that, but sometimes it can be a presentation. So if it's a presentation, you can imagine, okay, this can be a clinical feature, because in combination with polycystic kidney disease, we may find cysts in other organs as well. Sometimes the patient may present with cerebral berryaneurysm. Berryaneurysm is a protrusion of cranial artery. So whenever we say aneurysm is always means a bulge in the artery. So why we are saying it's berry? Because of its morphology. So if the cranial artery is bulged, so we can say it's a berryaneurysm. So sometimes those who are having this polycystic kidney disease, they are also having this berryaneurysm. So you must evaluate the brain scan. You must do the brain scanning also, just in order to be sure that if the patient is having polycystic kidney disease, they should not have this one. Because if there is too much hypertension, too much blood pressure, anytime the cranial artery can be damaged, and there will be of course, sudden death of the patient. There's always a risk of sudden death of the patient. Okay. And then we have the risk is higher in patient with a family history. Of course, we have to rule out it's a genetic disease. For genetic disease, we have to know the family history, of course. May rupture and cause subarachnoid hemorrhage. If we are considering the bulge in the aneurysm in the cranial artery, we should be very vigilant, because there are chances of subarachnoid hemorrhage. Not only the brain, but the heart can also be involved, those who are having this PCO. So they can present with cardiovascular findings as well, because the polycystic kidney disease results in hypertension. Hypertension can lead to arterial hypertension, can lead to morning headaches, can lead to increased renin production, heart valve. Sometimes you will find some defects in the heart valve. Say, for example, you will find mitral valve prolapse here. So prolapse can be there. So you may find if a patient is also having this one, you can think about this one, that this is the correlation. Those who are having polycystic kidney disease, they can present with mitral valve prolapse. It's not like the mitral valve prolapse is always be there whenever there is PCOS, but there is a strong correlation, because we usually see there is a clinical presentation that the patient can present with MVP. Colon diverticula, abdominal and guanal hernias, also in these patients we can see these disorders. So all these clinical features will help you that maybe these are the manifestations because of polycystic kidney disease. They can be present together as well. Now, if you are considering autosomal recessive, so for recessive one, they are saying symptom most commonly manifest in infancy or childhood, and these symptoms are showing you the protruding abdomen, especially the child who's having this abdominal swelling or bilateral renal enlargement. Liver is also increased here. The baby can end up in chronic renal failure as one. So what are the signs of chronic renal failure? If the baby is having blood in urine, if the baby is having high proteinuria, if the baby is having low urine, especially if passing low urine, so oliguria is there, high proteins is there in the urine, and plus if blood is there in the urine, you can say these are the symptoms of chronic renal failure. These are the presentation of chronic renal failure. And severe in utero renal impairment. Sometime before delivery also we will see this thing, like oliguria in utero as well, maternal oligohydramnios. How we will differentiate if inside the mother the baby is having less urine, you will find low amniotic fluid index. So low amniotic fluid index, we usually monitor amniotic fluid index in the mother just to see whether the baby's kidneys are working properly or baby's esophagus are working properly, because the amniotic fluid is the one the baby who's going to eat and that's going to be excreted. So if amniotic fluid levels are low, you can have a suspicious, then an anomaly scan. Your sonologist should check the kidneys just in order to rule out whether kidneys are normal or having cyst inside. So severe in utero renal impairment, so that is called Potter sequence. Potter sequence means what? You will see the low amniotic fluid index in maternal bodies. The one who is pregnant mother, and if you see the low amniotic fluid index in that mother, you can say it's a Potter sequence. And once you do the anomaly scan of the baby, you will find the cysts. That's why you know the cause. Okay, the cause is this one. The baby is having polycystic kidney disease. That's why the baby is producing less urine. That's why the mother is having low amniotic fluid index. Okay, some craniofacial abnormalities can also be there. These babies have club feet, these babies have flat nose, low set ears, and retrocanthia. So these are also some craniofacial abnormalities that can be associated with this one. Pulmonary hypoplasia, respiratory insufficiency. The neonates can present with symptoms of respiratory distress. That can also give you a clue if the baby is having. So those babies who are already diagnosed on the basis of an anomaly scan that they are having this polycystic kidney disease, you should be very vigilant of during, especially if the resuscitation is concerned soon after birth. Soon after birth, you have to have a vigilant eye monitoring on these babies, especially if respiratory distress is concerned, because these babies can easily go into respiratory distress. These babies also present with extrarenal manifestations. Say, for example, they can present with hypertension, early manifestation, often responsive to monotherapy. It's not like that it's not going to be controlled. Of course, we can control this hypertension, can result in complication. But if it's not, if it's not going to be cured, it's treated properly. Say, for example, if you're considering home deliveries, or if the mother is not going for the proper, antenatal follow-up, then you may find that these babies can present with severe complication. Cardiac hypertrophy, heart failure, cerebrovascular disease can be there in those babies if you are not going to treat the hypertension in those babies. Liver involvement, congenital hepatic and portal fibrosis can occur, and you will see liver failure. So see, these polycystic kidneys are very lethal presentation, especially in autosomal recessive condition where childhood or especially infancy babies are involved, and they can be a progressive liver failure in this patient. So early diagnosis and prompt treatment is a must in autosomal recessive one, so that only we can get over these complications. So how you're going to diagnose if the patient is having this polycystic kidneys? Of course, first of all is ultrasound, and if we are considering about the recessive one, we can go for an anomaly scan. So for the autosomal dominant one, if we are considering the adults one, we will see large kidneys with multiple cysts bilaterally of varying size. In children also, we can see evidence of cysts in combination with family history. So for children, we should inquire about the family history, and we will easily see on ultrasound these multiple cysts inside the kidneys. And not only there, you can also find the cyst in liver, pancreas, and a spleen as well. For the adult one, autosomal recessive one, in large kidneys with multiple cysts, again, diffuse increased echogenicity despite the presence of liquid filled cysts. So you will see decrease, only these are the findings of ultrasound. You will find this anechoic area. Whenever there is anechoic area, you should always think about there is something fully filled with liquid. So cysts are there and they are filled with liquid. So you will find on ultrasound there's a complete blackish area. So on ultrasound, if blackish area is there, you should always consider about that area is filled with either gas or that area is filled either liquid. Then hepatic cyst also, you will see hepatic portal fibrosis can be there. So the best one you are going to memorize there is always the ultrasound. Then of course we can go for the CT scan, we can go for the MR angiography. We will see exactly what kind of, if there is any aneurysm or not. We can go for some genetic testing. Of course, genetic testing is considered to be the most accurate one, where you will see exactly what gene is missing, D1 or D2, so that you can clearly go for the definitive diagnosis, whether it's a recessive one or it's a dominant one. And some other lab tests you will do, say for example, tracking test, blood count test, urinalysis. These are all the supportive tests you can do, and whatever the symptoms are there, you will go for the symptomatic treatment. So for the treatment point of view, always consider that these patients, whoever is having recessive one or dominant one, the usual presentation is hypertension. So we should control the blood pressure. In order to do that, we can give AC inhibitors, we can give ARB, that's angiotensin converting enzyme inhibitor. That's the most important thing. This is the most important first line medication we should start in control of BP. Or maybe we can give this is at the 12-10 indicated in patient with rapidly, those who are having this rapidly polykidney disease associated with chronic kidney disease, we can give this one. The main aim of this 12-10 is actually it's what? It's a vasopressant. It's going to a competitive vasopressin 2 receptor antagonist. It's an antagonist. Antagonist means that whenever there is vasoconstriction, it's going to release that constriction, so that thereby decreasing the blood pressure. Because there is too much hypertension here, even the patient is having CKDs. So what our main goal is, wherever the vessels are constricted, we can give this 12-10. It's going to inhibit the vasoconstriction, converting into vasodilation, and thereby decreasing the blood pressure of the patient. We will, of course, avoid nephrotoxicity. We will not give anything who's going to excrete it from the kidney. We want to decrease the workload of kidney. In severe cases like those who are presenting with end-stage renal disease, we have only chance for hemodialysis. We can only go for peritoneal dialysis, or maybe we can just transplant the kidney. So kidney transplantation, as we have discussed in the summary, that is the only preferable choice if you are seeing the patient is ending up with chronic kidney disease or ending up into end-stage renal disease. So now let's look at the questions here. A 30-year-old patient present with recurrent urinary tract infection. Now he is having 30 years old, having multiple UTI infections, polyuria is there, and electrolyte imbalancing is there. So electrolyte imbalance must be there because of too much UTIs and too much secretion of urine. Now on ultrasound, once you do the ultrasound, that is a basic thing. Even with the help of this one, you will never get an idea that this patient is having polycystic kidney disease until you do the ultrasound, and you will find cyst on the ultrasound. But of course, these are the presentation, and based on these presentation, we will always go for ultrasound. But seriously, if the patient is coming to me and he's having multiple UTIs, I should go for urine DR first and urine culture first. These are the supportive initial testing, but they never considered to be the best initial one. Ultrasound bilaterally enlarged kidneys with multiple variably sized and thin walled cysts distributed throughout the renal parenchyma. So this patient was having renal compromise based on the patient's on the renal symptoms. For the renal symptoms, we advise ultrasound, and on ultrasound, if you see clearly, the thing is mentioned multiple variably sized and thin walled cysts. Now they have a clear diagnosis with you that this is a case of polycystic kidney disease. Which of the following is the most likely diagnosis? Of course, or if on the basis of ultrasound we have found out the cyst, it's a case of polycystic kidney disease. Without ultrasound, you can never ever imagine. You can just only think about the renal symptoms. Renal symptoms are here. Then in my DDH must be or any kind of infection of the kidney, any kind, something related to acute kidney injury, something related to chronic kidney injury, chronic kidney disease. So in DDs, you must have so many things. But once you have the finding in front of you, say for example, ultrasound finding, you can easily say it's a polycystic kidney disease. Okay. For the next one, we have to go for the theory. Next, we have this plantar fasciitis. Let me take you here, 422. Okay, plantar fasciitis, very common clinical presentation whenever the patient comes to you and he gives you a history that doctors, as soon as I get up early in the morning and I took my feet over the ground, there is a sharp excruciating pain in my heel. That is the usual presentation. Say, for example, the one who is having procedentia, they usually say something is coming out from my vagina, and you will always think about, okay, this may be a case of UV prolapse, something like that. If the patient says to you that early in the morning when I usually get up and I put my feet just on the ground, and by hitting the ground, my heels are having so much pain, that must be a case of plantar fasciitis. Only for your clinical knowledge, I'm saying this one. So plantar fasciitis present with very severe pain in the bottom of the foot near the calcaneus. Calcaneus is your heel where the fascia inserts. It is of unclear etiology. We don't know the reason why it is happening, but the pain is worse in the morning and improves with walking a few steps. So first, the patient is going to keep the foot down. He's having excruciating pain in the heel. Always consider plantar fasciitis. Now, there is a point tenderness at the bottom of the foot where the fascia insert at the calcaneus. So, Achilles of tendon, you must have remembered anatomically, Achilles of tendon, all the muscles of the back compartment of thigh, they are going to merge together and they are going to be inserted here on the top of the calcaneus in the form of Achilles of tendon, and that Achilles of tendon is actually creating this pain. They're saying there's a point tenderness at the bottom of the foot where the fascia insert at the calcaneus. You can distinguish this from tarsal tunnel syndrome because the pain of that disorder worse with use. If the one who's having tarsal tunnel syndrome, the more he's using his feet, the more pain is going to be there. But in case of plantar fasciitis, only just at the beginning of the start, like in the morning, first step, the patient is experiencing pain. But once the patient takes some step, 4-5 steps, or maybe he just roam around, he will find it better. So plantar fasciitis pain is going to better as soon as the patient starts walking. But of course, if there is tarsal tunnel syndrome, then what will happen? There the nerves are actually trapped and compressed. Those patients, when they move, they have more and more pain while walking. So that you can differentiate in between tarsal tunnel and plantar fasciitis. Now they're saying, and plantar fasciitis clearly improve with use. So of course, as soon as only the first step is going to be very painful, as soon as the patient starts walking, he will feel better. Treatment consists of stretching exercise. Of course, it's a tenderness in the Achilles tendon. It's a tenderness in the tendon. So we'll just ask for the stretch exercises. We'll give support, arch support. We will advise some medicated shoes for these patients and NSAIDs. If inflammation is there, you can just go for the supportive treatment. A steroid injection, steroid will act like a magic. So, but of course, it's not a very good choice to give a steroid to everyone. If these don't solve the problem, then only you can go for steroid. Surgical release of the plantar fascia is really necessary. It's very rare that we'll go for the fasciotomy. We'll just remove the fascia or cut the fascia. Usually, it will go only with the help of supportive exercises. Like we'll ask the patient always use high arch heel shoes so that can help the patient. So X-ray of the foot is not useful. In plantar fasciitis, there is no correlation with the presence of heel spur. There is no relation with the heel spur. There is nothing you can find on X-ray. It's just a clinical diagnosis. It's just the fascia, which is actually having tenderness. And the very usual presentation is morning pain just after taking first initial step. And then it will get better. So let's have a look at the question here. Here the question says, a 23-year-old athlete presented with foot pain. Now you can obviously understand he's an athlete, so too much exercise must be there. So the tendon can be tender at any time, fascia can be tender at any time with foot pain while standing and walking. On physical examination, there was significant tenderness on the midline plantar surface of the foot. Now, once you do the examination, you can easily find tenderness on the midline plantar surface. The patient denied any history of trauma. There is no history of trauma, which of the following is most likely diagnosis. So what do you think? What can be the diagnosis here? Just 1 minute. Just give me a second. Okay. Okay. So, do you think it's a hallux valgus? What do we mean by valgus and rigidus? These are, if you're considering this valgus, it's just related to big toe. The big toe is very pointing and bending outward. That is called hallux valgus. You want me to show you the picture? I can show you the picture of that. It has nothing related to this one, but just have a look so that you can have an idea that hallux valgus is related to big toe. It's not related to fascia, plantar fascia. See this one. This is especially it's called a binion actually. It's your big toe pointing and bending outward. So if big toe is bending outward, this is a hallux valgus. So of course this is not the condition here. The next one is hallux rigidus. Rigidus also, if you could just look here. Rigid sometimes called turf toe or stiff big toe when you have a big toe pain. So it's just here the one who is having big toe pain. So the DD can come to your mind related to a gout, right? But it's, of course, it's not a plantar fasciitis. Plantar fasciitis has all the thing related to calcaneum. This is the heel bone calcaneum. So here you will find if the patient is having pain, then you can think about this one, not towards the big toe, of course. And what is the next?
Miss
Choice?
Dr. Hira, which is the
Yes.
bone above calcaneus?
Sorry?
Which is
That's,
the bone above calcaneus?
which bone above calcaneus?
Yeah.
Which one? Calcaneum is a heel bone. This one.
Where is the other big bone? Where is the other big bone of heel?
Talus, you are talking about talus?
Yeah, yeah.
Talus is in front. Talus is in front and calcaneum is behind.
Okay.
See, this is talus. This is talus and this is calcaneus. So here, if you see plantar fasciitis, this one.
Okay.
This is the fascia and
Tibia fibula are attached with the talus, huh?
Exactly. Fibula. Head of the fibula. Okay, and what is the next one? Carpal tunnel. So of course, tarsal tunnel. So tarsal tunnel, of course, here you will see compression of the nerves. It has nothing to relate it. Which nerve is compressed in tarsal tunnel? It's an important question. Posterior tibial nerve. So posterior tibial nerve is actually compressed here in the tunnel. So that can cause especially pain all over the foot. And usually the presentation is pain or tingling sensations or numbness in the foot. So the one who is always complaining pain in the entire foot, think about tarsal tunnel syndrome where the posterior nerve is actually compressed. So of course, this is not the presentation because here the patient is only on examination, there's only the plantar surface of the foot which is standard. So you will always think about plantar fasciitis. Okay, so this is all about this. Thank you so much, everyone. So tomorrow, inshallah, we'll do at 7:30.
Thank you, Dr. Hira.
Thank you, Dr.